Okay. All right. We're ready for round two. All right. Okay. So I was talking about hip dislocation and the position that you want to avoid when you do the posterior approach on total hip arthroplasty is flexion of the hip with adduction, and internal rotation. So in case you're wondering what that looks like, here's how you can picture it in your mind. Picture an 85-year-old woman sitting on a toilet bowl to urinate. All right? So what that entails is this. I know you probably can't see me in Worcester anymore, but basically, for those of you in Manchester, she's sitting on the toilet, and her legs have come together, and her feet are out a little bit. She's like this on the toilet. Okay? This is flexion of the hip, adduction towards the midline, and internal rotation. So it basically looks like this. This is the position of dislocating your hip. Okay? So why did I use the example of an old woman sitting on a toilet? Because one of the things you give patients to prevent this from happening is a raised toilet seat. So it fits over the regular toilet seat, and it puts them up a little bit higher. What happens when you sit a little higher on a toilet seat is you naturally move your legs apart more to keep yourself stable on the seat. So that is a way. Now, I don't know who thought of that, but genius. Brilliant. It works. And we have a lot less people dislocating their hip. So the other problem is side sleepers. If you're a side sleeper and you flex your hips and bring your knees up a little bit, that will also result in internal rotation and adduction of your hip. So we provide the patient with a wedge. The wedge is a small triangular piece of foam that straps to the leg. You put it in between the patient's legs. They strap their legs. Each leg is strapped to the foam. And now when they lie on their side, they kind of look like a wishbone, like this. And they can't bring their knees together. And when they realize that that's way too uncomfortable, they sleep on their back. Okay. So post-op follow-up for us lasted 2 years. We followed patients for 2 years after we did a total hip. And the biggest problem that we face, or one of our major concerns, is infection. Antibiotic prophylaxis is what we do to reduce the risk of infection at the time of surgery. And we generally continue the patients on antibiotics for at least 24 hours post-op. So they get a dose just before surgery, and then they stay on the IV antibiotics for 24 hours, and then we stop them. And that reduces the risk of infection. Now, there's some discussion from the infectious disease people as to whether that's needed at all. And most surgeons' attitude, because, again, we're putting in a prosthetic. If it was just regular kind of surgery, we wouldn't care so much, but a prosthetic is a foreign body. If you get an infection, you have to take the joint replacement out, and it creates a nightmare. So most surgeons' attitudes about this is basically, yeah, I get the science, I get it all, I understand it, but I'm not doing it with my patients. So unfortunately, as a result, lots of surgeons continue to use prophylactic antibiotics, much to the chagrin of people in public health and in infectious disease. But again, the surgeon's attitude is, hey, if this patient gets infected, you guys ain't helping me. It's my problem. So that's what most surgeons are, in fact, doing. Trochanteric bursitis, you're going to see a lot of this in primary care. The pain is right over the trochanteric bursa. We've talked about this already. Any movement will aggravate the pain, so patients will often complain of pain when they walk. And on exam, you can palpate right over the bursa. The easiest way to do that is have the patient on the table lying in the lateral position, lateral decubitus position, where they're lying on their side, and that will bring the trochanteric bursa up closer to the surface. You palpate it, the patient will tell you that's tender, and then you confirm with the patient, is that the pain you came to see me about? And when they say yes, then you've made the diagnosis of trochanteric bursitis. You can treat it with heat, anti-inflammatories, things of that nature, but usually the most successful treatment is cortisone injection, which sometimes has to be repeated more than once because it's not always possible to hit that bursa. You're trying in 3 dimensions to get your needle right to the bursa, and if you go a little too far, you might pass it. If you go not far enough, you're not going to be in the bursa, so sometimes it's a problem. You can also provoke the symptoms by having the patient lie on their back and then sort of bringing them into the figure 4 position where you kind of externally rotate the hip and you flex the hip and the knee, and so you bring that leg out into like a V, and with the other leg it forms like the figure 4, and when you push down on the medial side of the knee to sort of push the leg onto the table, what you'll discover is that that the patient will say, ow, 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 and it hurts. Meralgia paresthetica. This is not necessarily something you'll see, but you will see it, I guarantee you. This is actually a fancy name for somebody who's wearing their pants too tight. And most of the time you'll see this on a man who is swearing that he can still fit into his 38-inch trousers, and he should be buying 42 or 44-inch trousers. And as a result, the belt and the trousers are way too tight, and it causes pressure and irritation on what's called the lateral femoral cutaneous nerve, right at the superior iliac spine. So again, if you have a patient who's complaining of pain in that area, and you notice that they're obese and that their pants are awfully tight, or if they're a construction worker and they're wearing a heavy tool belt, that's another reason that you see it. And then basically the best treatment for this is to literally just tell the patient to go out and buy a pair of pants that actually fits. And again, the pain will be over the anterolateral thigh, so we can often mistake it for either a hip problem or a back problem. And then you can reproduce the pain with pressure to the just medial to the anterior superior iliac spine, or with extension of the hip. So again, you put the patient on the table as if you were doing a psoas sign, you pull back on the leg and you will reproduce their pain. Weight loss, looser clothing, and sometimes the cortisone injection, but I'll tell you, I never gave a patient a cortisone injection for this. If they get looser clothing, the problem will go away on its own. Snapping hip. This is often not associated with pain, but patients get annoyed by it. They just want some reassurance that they're not destroying their hip. They're not going to wind up with arthritis in their hip at a young age. And most of the time, the problem is a tight iliotibial band. This is a band that goes from your hip area, the ilium, down to the tibia. And it's overly tight, so with movement, it catches over the greater trochanter. And so the patient perceives this as a snapping sensation. Most of the time, all the patient needs is some reassurance. Little stretching exercises can be helpful, and heat can also provide relief. It's not in and of itself pathological in that it's going to create a problem for the patient down the line. So let's move on to the knee. The knee is a very cool joint, if I can say so. It's a modified hinge joint, and it really is one of the only bones in the body that forms a joint with 3 bones, not 2, your patella being part of the joint. So again, distal femur, proximal tibia, and the patella. The femur has a little groove in it in which the patella fits in the groove. And every time you bend and straighten your knee or extend and flex your knee, your patella moves up and down in that groove. And it needs to fit in there precisely, otherwise you're going to have anterior knee pain problems. So the main plane of motion for the knee is pretty simple. It's flexion and extension. There is another element of rotation to the knee, but it goes beyond the scope of this talk. The things that we get concerned about with that will actually accelerate the process of developing osteoarthritis is patients who have a deformity of their knee, either a varus deformity or a valgus deformity. Remember, a varus deformity, the angle of the angle created by the deformity points away from the midline. With a valgus deformity, the angle created by the deformity points towards the midline. So a varus deformity of the knee, if you had 2 varus deformities of the knee, you would be bow-legged. If you had 2 valgus deformities of the knee, you would be knock-kneed. Okay, so that's another way to remember. So the basic bony configuration of the knee makes it inherently unstable, but the knee has 4 ligaments to try and stabilize it. 2 of them are extrinsic, 2 of them are intrinsic. The 2 intrinsic ligaments are the anterior and posterior cruciate ligament. The word cruciate means crossed, and the ACL and the PCL form an X inside the joint. Remember that the ACL defines the limits of motion of the tibia moving anteriorly on the femur, and the posterior cruciate defines the motion of the tibia moving posteriorly on the femur. So the ACL is the brake as the tibia slides forward on the femur, and the PCL is the brake as the tibia slides backwards on the femur. The lateral collateral ligaments, of which there's the medial and lateral, also help define the motion of the knee, but they are much more restrictive in that there's not a lot of lateral and medial movement of the knee. In addition to the ligaments, there's also the capsule, which is the synovial containment of the joint. The menisci also provide some stability of the knee, as do the muscles, in particular the extensor mechanism. Again, the extensor mechanism is made up of the quadriceps muscle, the quad tendon, the patella tendon, and the tibial tubercle. And remember, the patella tendon, although we call it a tendon, by definition, we really should call it the patella ligament, because ligaments basically are the attachment between bones. So the tibial tubercle and the patella are both bones, so technically it's a ligament. But from a histological standpoint, if you looked at the patella tendon under a microscope, it has the properties of a tendon and not a ligament. Okay, so the knee is actually a complicated joint, and as such, the problem of diagnosing the problem in the knee can be complicated as well. But if you understand the anatomy of the knee and you know some of the common problems, you should be able to have a reasonable approach to a patient who presents to you in the primary care setting with knee pain. Okay, so we kind of talked about this already, and we pretty much talked about this already, and we talked about this already. So the thing to remember, again, for the MCL is the force comes from the outside of the knee. This is why there's so many more medial collateral ligament injuries than lateral collateral ligament injuries. If you remember, the medial collateral ligament is, of course, on the inside of the knee, so sort of intuitively one would think, well, if the force comes from the outside of the knee, why would you injure the ligament on the inside? And the reason is because when that force, if this is my right knee, when that force comes from the outside and the leg bends this way as a result of the force hitting the knee, it pushes the knee into a valgus position. And by pushing the knee into that valgus position, it stretches the medial collateral ligament on the medial side. So the injury on the lateral side would be more like a contusion injury, which is not a big deal. But the injury on the medial side would be either a stretching or a tearing of the MCL. The opposite would have to occur for you to get an LCL injury, and you just don't find that many varus forces that hit the knee from the inside. Most of the time we see this, and this is a common injury in football players, particularly runners who may be tackled from one side or the other, and as a result they get a valgus stress to their knee, and it tears the MCL. Okay, so the extensor apparatus is very important to the knee. It straightens the knee. It also prevents the knee from buckling, because when the knee buckles, it bends. And when it bends, it means that the extensor apparatus that's keeping the knee locked has failed. Patients who have torn menisci will often have the illusion of instability in their knee. And I say illusion because it feels like their knee is going to buckle, but they don't fall. And that's the key. If the patient says, my knee feels like it's going to buckle, it feels like it's going to give out on me, the first follow-up question you should ask is, do you fall when this happens? If the patient says no, and you're thinking that they may have some injury to their knee, it is probably not an ACL, because when they have an unstable knee because of an ACL, when their knee gives out, they will fall. But with the meniscus, it's merely an illusion. The patient always says, oh, I catch myself before I fall. Well, they don't really catch themselves. There's no instability here. The meniscal tear is not really making any significant functional instability, and so the patients just do not fall. The quad muscle is very important to the stability of the knee because it is the shock absorber for the knee, and it is the major portion, or one of the major portions, of the extensor apparatus. What happens is, a lot of times, is I'll see a woman in the office who comes in, a young woman who comes in complaining of knee pain, no history of injury. I talk with her a little more about injuries, and she tells me that 3 months ago she injured her ankle, had a bad ankle sprain, was out of her sport for an extended period of time, and just recently got back into her sport. She's been protecting her ankle because obviously she's still in the final stages of recovery. However, she's perplexed by the fact that what's hurting her is not her ankle, but her knee. The problem there is often that the patient has a borderline alignment problem with their kneecap. While they were away from their sport and nursing their ankle injury, they started to have a deconditioned quadriceps. Now the quadriceps is deconditioned, and now they've gone back to their sport, and their quadriceps is not able to function the way it should normally, and so their borderline patellar alignment problem, the one thing, or one of the things that was keeping it in check, was a well-conditioned quad. They don't have that anymore, so they become symptomatic. The treatment for that is back off from your sport, because if you continue to do it, your knee is going to continue to hurt. Back off from your sport, work at rehabbing your quad, and then gradually get back into your sport. There are some braces that we can give the patient that will help with the realignment. Basically, it's not really so much of a brace as it is a sleeve. It's a sleeve. The patient puts it on. Their kneecap pops through the little hole in the sleeve, and there's a little bar inside the sleeve that pushes their knee into a better, their patella into a better alignment. So this is looking at a knee. This is the patella tendon, and it's been cut down here on the tibial tubercle so that it can be reflected back. So you're seeing the back part of the patella. This is the part of the patella that goes up and down here in the groove in the femur. Okay? This is the femoral surface with the articular cartilage. This is the anterior cruciate ligament. This is the posterior cruciate ligament. This is the medial collateral ligament. How do I know this is the medial collateral ligament? It doesn't say right or left knee. The reason that I know is because here's the fibula, and the fibula is on the outside. So this has to be the medial side of the knee. Therefore, this is the lateral collateral ligament, okay? The lateral collateral ligament goes from the femur to the fibula. The medial goes from the femur down to the tibia, below the tibial flare. This is called the tibial flare, okay? This is the meniscus. The meniscus is C-shaped. This is the lateral meniscus, and the medial meniscus is partially out of view, and the front of the meniscus is here. It's C-shaped. It comes up a little bit more on the sides. It provides some stability and some additional cushioning inside the knee. When people talk about a torn meniscus or a torn cartilage, I should say, when people say I have a torn cartilage in my knee, almost always they're referring to the meniscal cartilage, not the articular cartilage, okay? Most of the time, this is, again, C-shaped, and most of the time, meniscal tears occur in what we call the posterior horn of the meniscus. So if you think of it, again, as C-shaped, this is the posterior horn, this is the anterior horn, okay? So the front of the meniscus is the anterior horn, the back of the meniscus is the posterior horn, and this is where most of the tears occur because that's where there's the most continuous presence of the femur on the tibia with the meniscus in between, and any sort of twisting motion will grind the femur on the tibia, and the meniscus is in between. This is why when you get older and this surface becomes rough, the meniscus becomes more brittle and dried out with age. Why patients who are older can get a meniscal tear with a relatively minor trauma, or even something simple, as I said before, as squatting down or kneeling down. Younger people often takes a more significant trauma to get a torn meniscus because these surfaces are smooth and the meniscus is nice and healthy and pliant. So here's your tibia, and of course when you get arthritis, you can get arthritis in one of three compartments. Okay, you can get arthritis in the lateral compartment, that would be the femur and the tibia. You can get it in the medial compartment, that would be the tibia and the femur, and you can get it in the patellofemoral joint, that would be the back of the patella, which is covered with articular cartilage, and the femur, the trochlear, which is the part of the femur where this trochlear is actually in here, but this is part of the patellofemoral joint. And both these surfaces are covered with cartilage. You can see that the patella has sort of a V shape to it, and the femur takes a little bit of a dip. So this part has to articulate with this part of the femur. If the patella is a little out of alignment or tilted, then these two parts don't line up precisely, and over thousands and thousands of repetitions, the patient develops anterior knee pain from patellar alignment or patellar malalignment. Okay, when you order x-rays of the knee, you should also obtain what's called a tunnel view. That will show you that sort of upside down U configuration that forms what we call the intercondylar notch. If you have a patient over 40 or you suspect that osteoarthritis might be the culprit, you should get a single-legged weight-bearing view. A single-legged weight-bearing view will give you a more dynamic picture of what the knee looks like when a patient is actually walking and moving around on their knee. Remember, as I said before, when we walk, we don't really have both legs on the ground for very much. Most of the time, one leg is on the ground and the other one is moving forward to take that step. When we reach that step, the other leg is lifted and that moves forward. That's how we walk. So in fact, your knee, when you're out there active, if you really want to know what somebody's joint space looks like, the best way to do it is with this single-legged weight-bearing view. You will now see what the joint space looks like when the patient puts not part of their weight, but all of their weight on that one leg. So it is the better x-ray to order, so you can actually get a more dynamic picture of what the patient's knee looks like under activity. The sunrise view is a view that you would get if you needed to look at the patellofemoral articulation. We call it a sunrise view because when you look at it, it looks like the patella is sort of the rising sun. I've seen some people call it a sundown view. You know, is the sun rising? Is the sun setting? I don't know. Could be either, I guess. But either one, if you order a sunrise or a sundown, you get the same view. And basically, this view lets you see how the patella sits in that little U-shaped area. So you see the way you see the angle is you see the way the patella is sitting in there, and you can see if the patella is in alignment or out of alignment. I think I have some x-rays that are coming up. So the ACL contains two bundles, an anteromedial and posterolateral bundle. Sometimes what happens is patients tear one bundle and the other bundle stays intact. If that's the case, sometimes the patient's knee is functionally stable. Notice the key word here is functionally. If the patient's knee is functionally stable, you don't have to do anything. People ask, well, aren't they more susceptible to tearing their ACL all the way in the future? And the answer is yes. And if that happens, then you do what you have to do. You do the reconstruction. But at that point, the knee is still functionally stable. And it may stay that way for the rest of their lives. So there's no reason to do an ACL reconstruction when a patient has a functionally stable knee. What do we mean when we say functionally stable? We mean that the patient's not having any buckling or giving out episodes, that the patient can do full activities, whatever their full activities are, including high-demand activities, and their knee stays stable. If that's the case, then they don't need a reconstruction. It's only when the knee becomes functionally unstable that we have to do the surgery. So even if your ACL Lockman maneuver feels a little different on one side than the other, sure, it probably is because one bundle is gone. But it doesn't necessarily mean that the patient needs an operation. And the PCL also has two bundles, and the medial and lateral menisci are fibrocartilaginous, and again, C-shaped. They cushion, they distribute weight, and they aid in stabilization. So the MCL taught in extension, and the posterior fibers are taught in extension, and the anterior fibers are taught in flexion. So either way you move your knee, that lateral movement of your knee is protected by the fibers, either anterior or posterior. And again, ligament injuries are graded 1 through 3. So a grade 1 would be a stretch or a very, what we would consider a microscopic tear. Grade 2 would be a partial tear, and a grade 3 would be a complete tear. If the ligament was to get stretched beyond its useful functional limit, then it would be considered a grade 2 or a grade 3, even though the ligament is still intact. The fact of the matter is most of the time the ligament tears. Sometimes the ligament tears because it tears right at the bony connection. And if you get an x-ray of the knee, you actually see little spicules of bone or a big spicule of bone at the point where the MCL would be attached, and that represents the tear. Naturally, you can't see the ligament, so you just see the bone disrupted, and you realize that's consistent with an MCL that has been torn, and it's actually torn right at the attachment to the bone. On physical exam with the grade 1 tear, the patient would have pain and tenderness along the MCL. Usually with the grade 1, you won't see any swelling or ecchymosis. And oftentimes there's either little or no laxity on examination, meaning that there's 1 to 5 millimeters of movement when you test the knee with a valgus stress. The treatment for this is pretty straightforward. It's rest, icing. Bracing is not usually needed here because the knee is not functionally unstable. And then early rehab when the pain subsides so the patient can get back to full activities. The grade 2, this is a partial tear, and as a result, partial loss of function. The problem here is you don't want to turn a grade 2 tear into a grade 3 tear. So the patient needs to be protective, and these patients generally are going to need bracing. When you examine them, there'll be 5 to 10 millimeters of laxity with valgus stress. These patients will have noticeably more pain at the time of injury, and usually if they get the injury during a sporting event, they have to leave the event and they can't return to the sport. Okay? Let's just skip the slide. Yeah, okay. So 5 to 10 millimeters of laxity, and then you might see some bruising or ecchymosis 2 to 3 days, and then the swelling. So the treatment here is the same as the grade 1, but these patients usually wind up with a hinged brace, and then these patients are certainly going to need some rehab, and they're usually able to return to full function even if there's high demand sports, even if you note some slight residual laxity on examination. So we don't get too concerned about that, and these patients just go about their full sports, etc. Grade 3, this is a complete tear. The laxity will be more than 10 millimeters. Interestingly enough, these patients have little initial pain. They may get pain at the time of the injury, and then after that, the pain fairly quickly resolves. And the rationale for that is everything is torn. The pain fibers, everything is torn, so there's not a real good way to conduct the pain back to the brain. So these patients are going to have significant laxity. They will develop swelling and ecchymosis. These are often unstable and will need to be braced for 4 to 6 weeks in rehab. Sometimes these need to be repaired surgically, but sometimes these will heal on their own as well. So it's not a given that these have to be operated on. Remember, the ACLs and PCLs, when they're torn completely, they never heal. But that's because they're in a different milieu. They're inside the knee joint and there's synovial fluid, and that's the reason why they can't heal in the fluid environment. This is very different, so these oftentimes do heal. Return to full activities comes when? Well, when there's no longer any MCL tenderness with palpation or valgus stress, and the patient has no real laxity on exam, and they have a full range of motion. And they're fully functional in their activities of daily living, and their endurance is pretty much normal. In order to return to their full activity, their high-demand sport, they need to have good strength. And the problem here is you put somebody in a brace and you limit their activities, and again, their quad's going to get weak. So these patients have to take the time to get their function back and get their strength back, and it should be at least 90% of their normal strength before you give them the okay to go back to full activity. Otherwise, they set the stage for them to get another injury. LCLs are really pretty uncommon. I don't think I'm even going to spend any time. It's on the slide there. The ACL, this is the most important single ligamentous stabilizer in the knee and is a fairly common injury. And again, it's the mechanism of injury here is a valgus force applied to a flexed, externally rotated knee. The foot is usually planted, and that's the problem. Because the foot is planted, there's no movement in the foot, and so the movement has to come from the next joint up. And the next joint up from the foot and the ankle is the knee. So as a result, the knee is stretched to a point beyond what the ACL can handle. And when the stress becomes greater than what the ligament can handle, the ligament tears. Lots of times these patients will tell you they feel a pop in their knee. Sometimes they even hear the pop in their knee. And they usually have immediate pain, and the swelling comes on fairly quickly. In the old days, when we had different bindings than what we have today, we saw a lot more of these injuries because bindings did not release when people were skiing. So people were skiing, they got a twisting injury to the knee. The ankle and foot was fixed because it was in the boot, and the boot was fixed to the ski. And so the next thing up that could bend or twist was the knee, and the result was the ACL would tear. So old-fashioned skis were ACL tearing machines. We always saw a lot more ACL tears on Mondays than any other day of the week because people went skiing over the weekend. So these patients will, if it's not treated, they will give you a history of buckling. And they will have falls associated with this buckling. These buckling episodes are devastating to the knee. With each of these buckling episodes comes a trauma to the articular surfaces, and that's why it's so important to convince patients to get their ACLs reconstructed. If they don't get the ACL reconstructed, then what's going to happen is they're going to continue to have these buckling and falling episodes. Aside from the injuries that they could get as a result of the falls, in addition to that, they're going to traumatize the articular cartilage surfaces of the knee, and the result of that is it's going to set the stage for early traumatic osteoarthritis. So if you're dealing with a 20-something-year-old person who has an ACL tear and they don't get it fixed, then the chances are, within 10 years or so, they're going to have traumatic arthritis of the knee, and they're really going to have a knee that's going to make them miserable. So how do the patients present? Well, obviously, they'll give you a history of a traumatic injury, oftentimes a twisting type injury, and many times they'll give you a history of hearing or feeling a pop in their knee. They'll have swelling, they'll have tenderness on exam, they'll have laxity with Lockman's or anterior drawer, and also look for associated injuries. A significant percentage of patients who develop a ACL tear will also have an associated meniscal tear. Some patients have a meniscal tear and an MCL tear as well as the ACL tear. This is called O'Donoghue's triad, also called the terrible triad. Some orthopedists look at it as the I will be able to put my kids through college triad. For obviously they're going to make some money doing the repair on this knee. So the interesting thing is when patients don't have the ACL involved and they have a medial injury or an injury to the medial side of the knee from a valgus stress or whatever, and you're scratching your head going, is this an MCL injury, a medial meniscal injury, or both? The interesting thing is that usually if it's an isolated injury and the ACL is not involved, it's almost always either the medial meniscus or the MCL, but not both. When a patient has a medial meniscal injury and an MCL tear, it's usually in conjunction with an ACL tear. So just, again, if you were examining a patient and you think they have both an MCL and a meniscal tear, but their ACL is intact, the chances are that it's either one or the other. But it's fairly rare to see a patient have an MCL tear and a medial meniscal tear. It doesn't happen that much. So you can get an X-ray here, but the X-ray isn't really that helpful because you don't see the ligaments. What the X-ray can sometimes do is you can get you see a little spicule of bone inside the joint. Just like a little triangle of bone or something. And that's actually almost pathognomonic for an ACL tear because that spicule of bone came from the ACL at the attachment in the femur, and it was torn off the femur, and the piece of bone is now floating around in the knee with the remnants of the ACL on it. And you can't see the ACL, but you can see the bone. So if you see that little bone, and I forget the name of the fracture that is, but if you see the little bone in there after you suspect an ACL injury, it's almost always an ACL injury. So the treatment, the MRI is really the gold standard. That usually you can pick up the ACL tear, but of course when you evaluate the patient, you're not going to have the results of the MRI the same day. You're going to book the MRI, and it might be days or a week or 10 days from the time you book it. So it's nice if you know that the patient has the ACL and you can prepare them because you made the diagnosis based on history and physical exam. And for the most part, most of these get reconstructed. You cannot repair the ligament for the same reason it doesn't heal. If you try to sew the ligament back together, it's never going to heal. Same reason, because of the synovial content of the joint. So you have to reconstruct the ligament. You have to take some tissue from some other place and reconstruct or reconfigure the ligament. And you want to do that right at the normal anatomical attachments of the ligament. If you don't, the ligament won't function properly, or the reconstructed ligament. So you want to put the femoral attachment of your reconstructed ligament right where the femoral attachment was for the original or the native ACL, and the tibial attachment the same. If you do that, then generally speaking, this reconstructive surgery is highly successful. And all I have to do is point to all the professional athletes who've had ACL tears, and while they miss a season, they all come back and are able to play their sport again because the reconstruction is good enough so that a high-demand athlete, professional status athlete, can go back and play their sport. Where that tissue comes from, well, you can take it. The classic one was to take a little piece of bone, a little piece of a narrow strip of the patella tendon, so that little piece of bone came off the bottom part of the patella, and it was just like a little, maybe 3/4 of an inch, so little not a spicule, a little bone wedge, and then a narrow strip, the same width as the bone, of the patella tendon, and then another similar piece of bone taken off the tibial tubercle. And that became the fixation, that became the new ACL. As the PA and the case, my job was to fashion the tendon into what we needed to reconstruct the ligament. So my boss would tell me how big he wanted the bone wedges to be, and he would, of course, drill us holes that would be comparable to that. But he told me how big he wanted the wedges to be, and I would trim down the bone, and then I had these little cylinders on my kit, and the cylinders were various circumferences, or diameters, I should say. So if he wanted an 8 millimeter or a 9 millimeter or whatever, I would then trim down the bone, and I would put I would drill 2 holes in the bone, drill them, this way, and I would put these heavy suture materials through it, and then I would try to draw the bone right through those cylinders so that I got a nice snug fit, but it was nice and smooth and easy. So that was part of my job, and then I would go back to the table and help him place the ACL. So it's a quite nice, interesting operation. If any of you ever get a chance to watch an ACL reconstruction, it's quite fascinating to watch. It's very cleverly conceived. I wish I had more time to tell you about it, but I don't. So anyway, but it's a cool operation. If you get a chance to see how it's done, I would say go for it. So how do we decide who gets a repair, reconstruction, and who doesn't? Basically, it's age dependent. So if you're 65 and sedentary and you tore your ACL and your knee is functionally stable for the things that you do, like walk, walk to the refrigerator, walk to the couch, that sort of stuff, you're going to be okay. So you don't need an ACL reconstruction. If you're a 22-year-old male, by definition, you have a high demand knee. Nowadays, even a lot of 22-year-old females, by definition, have a high demand knee. If you have a high demand knee, then you need a reconstruction. You don't have to wait for the patient to become functionally unstable. You just do the surgery. If the patient is sort of in between and you're not sure and they're not sure, then you can wait and see. And if the patient is showing signs of being functionally unstable, you do the procedure. It's a very, very good operation. It's very reproducible. So in the right hands, you will get a good result just about every time you do the surgery. The other thing you can use, if the patient doesn't want to use their own patella tendon, you can use what's called the semitendinosus, which is a tendon from the back of the leg, from the hamstring. It attaches on the front, on the tibia, and you can use that, a strip of that tendon. And what you do is you fold it in half, and then you fold it again, so you have 4 strands, and that becomes your new ACL. The disadvantage to that, and it's not as much of a disadvantage as it used to be because we have better technologies now for fixing the proximal and distal end, but what used to be the disadvantage to that was there was no bony fixation. With the ACL where you use the patella tendon, you have a bony wedge in the 2 tunnels that you drilled in the patient, and so you're bone up against bone. And that makes for a better fixation, at least initially. The bone eventually fuses. With the tendons, the semitendinosus tendon, you can still get good fixation. It's just as good in the long run, but it may not be as good right in the beginning. But now we have things where we use biodegradable arrows and things that we can use, and we get really good fixation anyway. But there's no disadvantage to the patient in the long term in terms of the quality of the reconstruction. The other thing is you can use a cadaver, and if you use a cadaver tendon, then it would be a piece of the patella tendon from a cadaver, and also under those circumstances you can use the part of the Achilles tendon, so you get a bony fixation point on one side where the heel is, and then the other side would be a non-bony fixation because the tendon would normally just go up to the muscle. So but those all work. They're all successful. Some patients don't like the idea of a cadaver part. They also don't want to take the risk of getting HIV, even though the patients obviously are screened and all the material is tested, but it doesn't mean that it can't happen. And certainly there have been cases of people who've gotten cadaver donations, just like cadaver organs, and then after the fact it comes out that the individual who donated was HIV positive or hepatitis B or hepatitis C positive. And of course, this creates a problem for the patient who got the organ and the tissue. So some people just say, you know what, I'll take the extra surgery, I'll take the pain of recovering from the donation part of it, and I get my own tissue, and I'm very happy with my own diseases. Thank you very much. I don't need anybody else's diseases, and it's really a personal decision. All ACL injuries need to be referred to ortho. The ortho person and the patient are the best people to determine what the course of action should be. Again, you can either use an autograft or an allograft. Allograft just means it came from somebody else. Autograft means it comes from the patient. And these are all now done arthroscopically. They're done, the scope assists you in doing it. It's amazing how small the incisions are now when we do this procedure. Post-operatively, patients are going to need an ACL brace. An ACL brace is a custom-fitted brace, custom-fitted from the standpoint that the patient is measured for it. They still usually get an off-the-shelf brace, but some patients, if you're a professional athlete, you're going to get a custom-made brace for you that will be perfect to your dimensions. And the ACL brace initially protects the knee just in case the patient falls or something untoward occurs. And then, of course, all these patients are going to need physical therapy to work on getting their motion and their strength back. It's going to require several months for complete recovery. I'm always trying to think of this guy's first name, and I keep wanting to call him Jim Rice. It's the great San Francisco 49er wide receiver, Jerry Rice. Right. Jim Rice was a baseball player on the Red Sox back in the 70s. They were both really good players, and for some reason I always want to call Jerry Jim, but Jerry Rice, great wide receiver for the San Francisco 49ers, played for other teams, but his greatest days were with the 49ers, and he tore his ACL in a exhibition game. And he went back, he got his ACL reconstructed, highly motivated guy. I mean, he said, I'm coming back this season. And his doctor said, no, you're not. And he said, yes, I am. And he rehabbed his leg and did everything that he should. And he was, like I said, I mean, guys like that are great patients because they want to get better fast. He went back, they got into the playoffs, so he went back and he played in their first playoff game, which was a mistake. He had a patella tendon, so he caught a pass. He caught it. It was a touchdown. But when he caught the pass, he landed right on his knees, both knees, boom, and he kind of, slid a little bit. And he got up. He trotted off the field, and that was it because he fractured his patella. And the reason he fractured his patella was because they had taken this little bone thing out and weakened his patella, and he didn't wait for his patella to completely heal, and so that happened. He came back the next season, but, the moral of the story is listen to your surgeon. So, in any event, PCL injuries, much less common. I'm not going to spend a lot of time. I have talked a little bit about this, but most common etiology of this injury used to be a dashboard injury, but now that there are airbags and people are wearing seat belts, although New Hampshire, as you may those of you who live here probably know, but maybe not in Massachusetts, we're the only state in the country that doesn't have a seatbelt law, unless you're under 16. If you're under 16, you have to wear a seatbelt. But our state motto, as you know, is live free or die. You could not wear a seatbelt, and you can change the motto to live free and die. But anyway, we do not have a seatbelt law. We forfeit a lot of national highway monies because of that, but that's New Hampshire. Live free or die. So if you're smart, you buckle up, even if you're in New Hampshire. And again, these airbags help too. But in the old days, we would see this. Why? Because patients weren't wearing a seatbelt. There was no airbag. The impact was such that they slid forward, and when they slid forward, their knee their knee clipped hit the dashboard. Their body kept going, but their tibia is sort of what stopped them. So their tibia hit the dashboard, their torso kept moving forward, and the tibia stopped abruptly, the femur kept going, and the result is that there would be a tear of the PCL. So that was when we saw the PCLs. You don't see this injury that much. You will get something called a sag sign if you bring the patient's both knees to 30 degrees. Because the PCL isn't there, and that's the break on the tibia moving backwards, what happens is the tibia slides backwards, and so when you look at the two knees, the dimples that usually you see in the knee, the one with the sag sign, the dimple's gone because the tibia has slid backwards. They'll have a posterior drawer sign, which in the hands of most non-orthopedists is usually mistaken for an anterior drawer sign, or they have what we call a reverse Lockman, which is mistaken for a regular Lockman. So many times I would see PCLs, I would see a PCL tear that was sent to me by a primary care doctor billed as an ACL tear. And the problem is the PCL tear is much harder to diagnose, and the primary care doctor, to no fault of the primary care person, didn't know how to diagnose the PCL, felt some laxity in the knee, and just assumed that it was an ACL injury. And considering that you probably see, 50 ACLs for every PCL, there's no doubt that people in primary care don't get very good at diagnosing this. So But if you know what you're looking for, you would be able to pick up a PCL every time. So these PCLs actually, patients are more, knees are more tolerant of a PCL deficiency than an ACL deficiency. So a lot of these patients are functionally stable. And even though the PCL's gone, they won't give you any history of problems with the leg buckling or falling or anything. But you can get them a PCL brace to protect the knee. The PCL reconstruction is far more challenging than the ACL reconstruction. And as a result, it's not as reproducible. And as a result, if the surgeon is smart and doesn't do a whole lot of these, you send them to a center where they do a little more of these and give your patient a better shot at getting a good result. Because the PCL reconstruction is far more challenging than the ACL. The problem if you have a knee that's down a ligament, and I'm not talking necessarily now about the PCL because usually the knees are stable, but the problem that you have with a knee that is functionally unstable and one ligament is torn is that the patient is more likely to tear a second and even a third ligament. And the problem now is you have a multi-ligamentous instability, and the prognosis for that patient, even with reconstruction, making a full recovery is not as good. So if you have a patient with an ACL tear, it's best to encourage the patient to get it evaluated and get it reconstructed. Meniscal injuries usually come about as a result of some kind of a twisting injury, but in older patients, again, something as simple as squatting down. The knee pain can occur immediately, which makes it easier to make the diagnosis. It's always easier to make the diagnosis when the patient comes to you and says, basically, my knee was fine, I hurt my knee, now my knee is in pain. It's real easy to figure out, I think that hurt knee must have had something to do with your pain. But when a patient comes to you and says, I hurt my knee 2 weeks ago, but it didn't start hurting until yesterday, it's a little bit harder to sort out because the tendency, if you're a good clinician, is to say, is the injury to the knee a red herring? In other words, is it something that has nothing to do with what the patient is telling me about now? So it makes things a little bit more complicated. But again, most of the time patients will give you a history of I injured my knee and it hurt immediately and it swelled up and it hasn't been the same since. But again, with that older patient, a lot of times they can get an injury and it's so incidental, it's so minor, they don't remember it. I used to see that in neurosurgery with head trauma in older people. An older person would hit their head. You know, one of these things where you leave a cabinet door opened and you don't remember, and then you stand up or you do something and you hit your head against the door. And for most of us, we go, ow, ooh, that hurt. You know, and then like 2 hours later, you forgot it even happened. 2 weeks later, you can't remember it at all. But in patients who are older patients, they can have cerebral atrophy, and they get an increased space up in their skull. And that increased space can hold a fair bit of blood. So they get their little subdural or epidural hemorrhage, but unlike a younger person with a brain cavity that's full of brain and gets sick right away, these patients don't get so sick. So 2 weeks later, they start having some headaches, they're getting a little confusion, they're having a problem. They come to see the doctor, and there's no history of trauma. Why is there no history of trauma? Because the patient said, I didn't hurt my head. My headache started, the day before yesterday. They're really bothering me, but I didn't hurt my head. So then they get referred to the neurosurgeon, and now the neurosurgeon you start looking at the scalp and looking to see if you can see the remnants of a bruise. And you say, you sure you didn't hit your head? And oftentimes I would say things like, sure you didn't hit your head like against a cabinet, or, start to suggest things to them only because a lot of times they did. And they forgot about it, and you sort of remind them, and they go, oh, I did. Or the wife chimes in and says, Harry, you did hit your head. Remember you told me you were holding your head? You came into the bathroom, and you said, oh, I hurt my head. I hit it. Oh, right. Boom. Now I have my history. Now I get the scan, and everything makes sense, and it all works out, right? So again, Do talk to your patients. Sometimes you have to just say, listen, something as simple as squatting down. When you're squatting down, were you washing out the bathtub or something? That's a classic way for people to get that injury. Older person, they want to wash out the tub, they squat down on their knees, kneel down the way that anyone would do to wash out a tub, and that's enough to give them the injury. So usually with a meniscal tear, they'll usually have swelling, and it will usually occur within 24 hours of the injury. This swelling is inside the knee. The MCL tear, if you have it, the swelling is around the MCL, but not fluid inside the knee. Remember, the ligament is on the outside. With the meniscal tear, there will be an effusion. An effusion means fluid in the joint, okay? Or effusion as we use it here, just like a pleural effusion. It's fluid between the pleura and the lung. This is basically a joint effusion. So the fluid is inside the joint, and usually will occur within 24 hours of the injury. Locking may occur. So again, this piece of meniscus is flipped up into the joint. And what happens is the patient will bend or straighten their knee, and they'll get to a certain point in either flexion or extension, and they pinch that torn piece that's popped up, and their knee just stops. And again, their interpretation is, my knee is locked. I can't bend it or I can't straighten it. Their knee isn't really locked. The problem is it hurts so much, they won't go past that point. And it might as well be locked because they're just not going to push their knee past that point. So again, the patients may come to you complaining of locking or buckling, but again, it's a buckling sensation. They don't actually have the falls like the ACL torn patient. These patients, again, can have significant pain, particularly when the knees touch, and they often will sleep with a pillow between their knees. Sometimes the patients they don't like their knee out straight, and if they're sleeping on their back, they want to keep their knee bent a little bit, so sometimes these patients will put the pillow under their knee so the knee can stay bent a little bit. So when you ask a patient about sleeping with a pillow between their legs, you can also ask for under your knee, because the back sleepers will want to do that. A lot of times these patients, when the knee goes into full extension, it hurts. And when you're examining them and you have them on the table, that's when you should place one hand on their thigh, just above their knee, and with your other hand, you grab their foot and hyperextend or attempt to hyperextend their knee, and more often than not, you will produce some pain on the part of the patient. The patient will tell you that hurts. And sometimes you can see that the knee doesn't come out to full extension when you compare it with the other one. They'll often have tenderness along the joint line, particularly on the side where they tore their meniscus, so lateral joint line tenderness for the lateral meniscus and medial joint line tenderness for the medial meniscus. They'll often have an effusion. They'll have a positive McMurray sign. McMurray sign is where you twist the knee around, you hold the leg, you bend it to about almost full flexion, you twist the knee around, and then you draw the knee out slowly into extension. If you hear a click, if the click is painful, if the patient complains of pain even without a click, we often call it a positive McMurray sign. The thing to be aware of is patients with osteoarthritis will often have a positive McMurray sign because their articular cartilage is beat up. So the McMurray sign, again, is not pathognomonic of a torn meniscus, but it's merely suggestive. If you have a younger patient with no arthritis, then the chances are you're hearing true McMurrays. The other thing that can lead you astray is a patella click. Sometimes patellas just click as you bring them out into full extension or as you move the knee around. And many times, because when you do this, you should have your hand at the top of the patient's knee, you actually can feel the click originating from the patella. And when that happens, usually I just say to the patient, was that your kneecap? And the patient will confirm, yes, that was my kneecap. More often than not, with a positive McMurray's, a click or the McMurray's maneuver will be painful to the patient. So first you rotate the knee in one direction, and then you rotate the knee in the other direction. And each time you do it, you draw the knee out into full extension. That allows all the surface of the meniscus to contact all the surface of the femur, and some point in that contact, the torn meniscus will make itself known. If you can't do the McMurray's because you can't handle the leg, you can do the Apley grind test. It's not usually quite as accurate, but for this one, you have the patient lie prone on their belly, you push down on their foot, and you rotate the knee again, hoping to bring this out. The treatment for these patients is most often a scope. MRI is the gold standard here, but I can tell you in my practice, I would see patients who are 6 or 8 weeks down from an injury and they still have knee pain, and they would come to see me, and I would basically tell them, you need a scope of your knee, you probably have a torn meniscus. And they would say, what about an MRI? And I would say, at this point, I don't see the need to get an MRI. If you had a minor injury to your knee, at 8 weeks it would be better, or even if it was a significant but non-surgical injury, you would be significantly better, if not 100% better, at 8 weeks. The fact that you're still hurting means there's something in your knee that is what we call it'll come to me in a second, internal derangement. You have an internal derangement in your knee, and the treatment for any internal derangement, whether it's a loose body, a torn meniscus, or whatever, is to put a scope in your knee and take care of it. So at 8 weeks, I would say to the patient, you don't need an MRI, and we'll just do the scope, and we'll find what the problem is, and we will take care of it. To which the patient says, oh, no, I want the scope. I want the MRI. And I say, okay, well, we'll get the MRI, but what do we do if the MRI is negative? So I would recommend, if the MRI was negative, that we do the scope. But the problem is your insurance company now has a negative MRI. And so they're going to say, we don't have a reason to do the scope. We're not going to pay for it. So I'm not saying you won't get your scope, but it may not be next week. It may be in 4 months. Because in 4 months, everybody, even the insurance company, will agree, you got something wrong in your knee. We need to put a scope in. But if that MRI happens to be negative, and a certain percentage of MRIs with a torn meniscus were negative, just means they didn't see it. Doesn't mean it wasn't there. So that was something for the patient to think about, and just adding another thing. But frankly, at 8 weeks, if you have significant findings on physical exam and your knee is still hurting you like it was when you first injured it, you need a scope. So I don't see the point of the MRI. Again, remember, when you're doing something and you want to order a test for a patient, it's very important to ask yourself the question, is the results of this test going to affect my treatment of the patient? If the answer is no, you don't need the test. Do what you're going to do, okay? So if the MRI is negative or positive, we're still going to say to the patient, we need to put a scope in your knee. So again, there's no point in doing the MRI. Okay, so post-op, let me give you a break, okay? I'm sorry, I know. I'm trying to get a lot of stuff in here, but I know you need to take a break. So 5 minutes and come back and we'll finish up what we have. Oh, you can get a Baker's cyst with meniscal tear. That probably is coming in another slide or two. But you can. The rationale for that is if the meniscus tears along the edge where the meniscus comes right out to the joint line, you now have a place for synovial fluid to get pumped out of the knee joint. And if it's in the right spot, and usually it would be like the posterior horn, but if it's in just the right spot, you can actually create a communication between the torn piece or the meniscal rent, that tear, and the bursa, the popliteal bursa. And the Baker's cyst is actually when synovial fluid gets pumped into that bursa, and the bursa blows up. It's really not a cyst in the true, we call it a cyst, but it's really the bursa that just fills with synovial fluid. initially the fluid can go back and forth. But it gets to a certain point where the fluid in the bursa becomes too thick, and it can go into the bursa because it's thin, but it can't get out of the bursa. So it just tends to get bigger. More often than not, if we just say to the patient, yes, we feel the Baker cyst back here, but that's not really your problem. What's causing you the pain is the meniscal tear. So let us just put a scope in your knee. Let us take care of the meniscal tear, and 80% of the patients will get better and don't need the cyst dealt with. We could, when we do the case, we'll put a needle in the cyst, but a lot of times it's too gelatinous, it won't come out, so you can't get it out. You don't want to just open it up. It's a huge incision. It's a kind of a Z incision. It's a big deal operation, and the bottom line is most of the time you don't need to do it. If you tell the patient, we'll take your pain away, you'll have full function of the knee, yes, you have this little lump back here, but it's not in a position that's going to create problems for you. See if you can live with it. 90% of the time, the patients will about 80% of the patients will get better without dealing with the cyst. 20% of them would say, I still have pain. So that's a different situation. Those patients, you need to go back and take care of. So if you saw that the cyst was really big and you palpated it and the patient's tamper on the cyst, those cases we would often say to the patient, we'll do one operation. We'll put the scope in, we'll take care of your meniscal tear, we'll turn you over and we'll do the cyst. Well, it's still contained within the bursa, but it's just, the problem is you look at it and you just, and again, you get an MRI when you see the cyst. So you look at the size of the cyst and you say, this is too big. It's going to continue to be big. And then when you examine it, you push on it, and the patient says that hurts. The other patients, a lot of times you examine them, you're on the joint line, it hurts, you do the McMurrays, it hurts, you bend and flex, and extend, it hurts, and then you push on the cyst, and you say, does that bother you? And they say, no. So those oftentimes, don't deal with it, just better left alone. When you have the situation where you look at the MRI and say, this cyst is really big, and then you push on it and it hurts, they're going to be in that 20%. That's not going to get better. So you might as well spare them the second operation and you just take care of everything first. The other group, where the cyst is smaller on MRI, there's no tenderness, more often than not, all you need to do is deal with it.
Really? Wait, I can't believe that discovered Okay. It only has my group exam. It doesn't have my individual exam. It does have my individual.
The group exam is all you need to know.
No, is it? That's their group.
Okay. Yeah, like
oh, I found it. Good.
Exam 2. All right. Oh, awesome. I emailed her. I was like, "Is there a problem?" She's like, "Oh yeah, I'll look into it."
What did the treat go on?
Sure.
Or surgery. What's your
And then glucosamine?
Yeah.
Do you take chondroitin too, or just glucosamine?
Broad question.
Yeah, probably does. Yeah, it probably does. There were patients that I certainly said you should take it. My feeling about that is it's probably not hurting you in any way, and it might be helping you. If you have a history of multiple surgeries to your knee, or at risk maybe for developing a traumatic arthritis, why not? I don't know that anybody has really proven. The problem with a lot of these things is all the information tends to be anecdotal, which means basically, somebody writes a letter to a journal saying, I have 4 patients who said they got, that they had a problem and their pain went away with glucosamine and chondroitin. And anecdotal information doesn't really sway the scientific community. The scientific community wants information that's a double-blind study. Nobody's really done that. At least not that I'm aware of. Maybe it's been done now, but nobody's really taken, two large groups of people in relatively similar circumstances. This group's going to get glucosamine, this group's going to get look at the results 15 or 20 years. Nobody's done that. So as a result, we don't have a really hard and fast effort. But my feeling is I haven't seen any. So my right, sure. Well, and part of it too is just sort of following up. At some point, you probably want a sympathetic weight bearing view of your knee, just to see what your joint space looks like. And if your joint space is looking more like the joint space,
There's no way that they
start, modifying your activities or finding activities that are less tough on your knee. I mean, the perfect example is the bike as opposed to the running. Again, some people are just, it's running. It's not the exercise, it's the running. That's what they need. And it's hard for people to make that change. The bottom line is...
What's my grade?
25, you look ahead and you think 50 sounds reaching. There's going to be a point in your life when you're going to be 50. Now you have to deal with joints as they are. And if, 50's not the end of life. There's a lot of life that comes after that. And if just walking is painful to you, then you sort of, might want to say, maybe I should have rethought my attitude when I was 25, even though my knee felt good. To take care of, yeah. Right. Yeah. Well, and there's probably no reason not to tell you to do this. For one thing, if you were my patient, I would have said to myself, this girl going to play field hockey after she graduates from college. Chances are the answer is no. Yeah. So my attitude would have been, yeah, go ahead, have fun, play field hockey. If I knew you were going to play field hockey for the next 15 years, we might have had a different conversation. But, field hockey is a sort of thing that, you don't see a lot of, pick up field hockey games. So you play it as an organized sport in high school, you play it in college, and then after that, you're done. So I would have done the same thing. I would have said, go, have fun. But maybe I would have had the conversation with you. At some point, you need to sort of, even if it's just to go, when you're 30, go and get an X-ray of your knee. And just be cognizant of what your knee is feeling like. So if the knee starts to bother you, don't wait. Get some good X-ray and see where you stand. Because ultimately, you need to last your whole life. That's the best. Anything short of that is not as good. Now you can be circumspect about it and just say, well, by the time I'm 50, that's some miracle joint and put in. And, people will be clamoring to get it because now I could be a better athlete with the joint. It's gone the other direction. So you don't know what's going to happen, but I would just be mindful of the knee. I wouldn't necessarily compromise my lifestyle, but at some point I would make a conscious decision. I need to get my knee checked. If you're having problems, yeah, it bothers me. Okay, so we're going to get started again. After a meniscal surgery, basically, what are you going to need to tell your patient? Well, the patient's going to have a dressing on there. It's going to be a big, bulky dressing. And about 3 days after the surgery, the dressing is going to be removed. One little stitch or staple through each of the arthroscopic portals will be removed. And at that point, the patient can begin some physical therapy. And generally, for me anyway, I sent all my patients who had scopes operatively for physical therapy. I didn't really let the patient convince me that they were going to be able to rehab their knee themselves. When they go to the physical therapist, I know they're going to somebody who's a professional, whose job is to rehab the joint. And so my feeling always was I wanted my patients to get the best care and to get the therapy, because the worst thing that can happen is you go back to a high-demand sport with a knee that's not fully reconditioned. You're basically setting the stage for getting more significant injury. Post-operatively, the patients would get, usually I'd give them Percocet. They take that for 24 to 48 hours, sometimes maybe 72 hours. After that, usually you can get by with something a little bit less potent. And then PT, normal activities usually were in about 10 to 14 days post-scope, and full activity was usually in about a month. The exception were meniscal repairs. If you do a meniscal repair, you're doing the patient a service by repairing rather than removing the torn piece. However, the patient's post-operative activities have to be modified to protect the area of the repair. What determines whether or not a meniscus can be repaired is not the attitude of the surgeon or the attitude of the patient, but rather the position of the tear on the meniscus. The only blood supply to the meniscus is out on the outer rim of the meniscus. In other words, the rim of the meniscus that's out by the joint line, out by the joint line. That's where the blood supply is. So if you get a tear out there, you can repair it because the blood supply will eventually heal it. But if you have a tear on the inner surface, the surface closer to the center of the knee, there's not a blood supply that's going to get out there, and the result is going to be that your repair is going to fall apart, the tear is going to be back there again, and you're going to have to go in and scope the patient again and do what you should have done the first time, which is to just remove the torn piece. The problem with a partial meniscectomy or a subtotal meniscectomy, partial meniscectomy means we took a piece of the meniscus. Subtotal means we took a lot more of the meniscus. It's just a question of, partial versus subtotal. If the patient has a subtotal meniscectomy, in other words, the tear is in an area that you can't fix, but it looks like it's a big part of the meniscus and we had to take a lot of the meniscus out, those patients will definitely be predisposed to osteoarthritis. If it was a relatively small tear, when we take out the torn piece, we take out the torn piece in such a way so we maintain the C shape. So we actually sort of trim the torn piece out in a way that doesn't change the original shape of the meniscus, because that shape has a purpose in the knee. And the more of the healthy meniscus we can leave behind, the better for the patient. Usually we'll put the patient on some anti-inflammatories. There's going to be some swelling in the joint. Again, I used to be a big advocate of preemptive pain control. So using some sort of pain medication prior to the actual surgery has been shown scientifically to reduce patients' post-operative narcotic requirements. So preemptive pain control is important. If it was in the form of having the patient take some Percocet before the surgery, or even more effective was filling up their knee with Novocaine or Marcaine before you even started the surgery, and just let that get absorbed into the tissues. And those patients did a lot better post-op as far as pain was concerned. And if you can control a patient's pain, you can get them mobilized faster. Meniscal cysts usually are accompanied by tears. It's a tear that is out near the joint line, and the result is that meniscal synovial fluid can sort of pump out and forms a cyst at the joint line, and these tend to be extremely painful. So the patient will present with everything that looks like a torn meniscus, in addition to which they have a painful lump out along the joint line. This requires more extensive surgery because you have to not only do the meniscal repair and or the meniscal meniscectomy, partial meniscectomy through the scope, but you then have to make another incision in the knee on the outside of the knee to deal with the meniscal cyst. So a little more surgery, a little more recovery time. A discoid meniscus is sort of a hypertrophied meniscus. It's a meniscus that instead of having the C shape is more like just a big glob and a big circle of meniscal material. The problem is there's too much meniscus there. It gets in the way. It starts catching on the surfaces and pinching and hurting, and the knee gets inflamed, and the meniscus swells up, and it's just just something that tends to become problematic. If the discoid meniscus stays asymptomatic, and of course you would never know that a patient has a discoid meniscus unless they came to you because they're having a problem with the knee. So if they come to you, they're having a problem, you can't find any other pathology, then that's probably the problem. And all you do in the surgery is you just trim back the meniscus to the point, to the shape and size that it should normally be. Chondrocalcinosis, this is our calcium pyrophosphate dihydrate deposition disease, commonly called CPPD. And this is basically, you can think of it as a form of gout. It's actually pseudo-gout. I mean, it really is gout, but the only reason it's pseudo-gout is because normally gout is uric acid, and this is calcium pyrophosphate. So it can't really be gout. So, for instance, if you check the patient's uric acid level with this problem, it would be normal because it's not the uric acid that's elevated. So the problem is these little calcific deposits can get onto the meniscus, and they can cause problems. Sometimes not necessarily. Sometimes the reason we pick this up, interestingly enough, is the patient comes to see us with something totally unrelated, but we get a knee x-ray. And these little pieces of deposit of this calcium pyrophosphate dihydrate is now littered throughout the meniscal tissue. And so it's radio-opaque. So what we actually see is something we never see, and that's we can see the meniscus on a plain x-ray. And so when you see that, you know that the patient has CPPD. And again, it may not be the cause of their problem. It might be, but it may not be. If the patient is, clearly has osteoarthritis, and I do the x-ray and I see this, I wouldn't recommend to the patient that they get a scope. I'd recommend that we treat their osteoarthritis and if we can't get them better. Plica. Plica is a sort of silky membrane of tissue that is in all of our knees when we were a fetus, and it usually dissolves at or around birth and disappears. However, in 30% of people, the membrane remains, and it's usually on the medial side of the knee. And for many of those people, I'm sure there are a number of you in this room that have plicas, since we're a big enough sample. And you will go through the rest of your life and never know that you had a plica because it doesn't cause a problem. But in some people, it does cause a problem. It gets in the way, it gets pinched, it's synovial tissue, so it's sensitive, and the patient starts behaving like someone who has a torn meniscus. However, the big head scratcher is no trauma. So eventually, sometimes if the plica is large enough, you can see it on an MRI. Sometimes you can't. This is a perfect example of that patient who 2 months of knee pain, no good explanation, but the knee's not getting any better. The MRI was negative. What are we going to do? Well, we put a scope in, and guess what? We find a plica. We remove the plica, the patient's pain goes away. So again, it just fits to that rule that if you have a problem in your knee that isn't getting better, more often than not, the treatment is a scope. Now, that's not always the case, obviously. I mean, and if you make another diagnosis, if somebody has rheumatoid arthritis in their knee, a scope is not the treatment. I'm just talking about mechanical problems in the knee that can cause chronic or acute and or chronic pain. So again, these patients look like a torn meniscus, and a lot of times what happens is these patients present, and they present to you with a torn meniscus. And so you say, okay, well, you got a torn meniscus. We're going to do a scope, and we put the scope in. And when we put the scope in, we do a full service checkup. It's like bringing your car in for a 50,000-mile check. So we look in all the different compartments. We look in all the places where problems can be. We take photographs of the inside of your knee. And lo and behold, what do we find in your knee? A plica. Well, this plica is going to be just like making a McBurney's incision. When you make a McBurney's incision, you take out the appendix. It's the same thing here. When we put a scope in your knee and we see a plica, we take it out. Even if you had a torn meniscus and the plica wasn't the problem, the rationale is obvious. We're here. We need to take this out because maybe a year from now or 10 years from now, you're going to have a problem with it. Why shouldn't we take it out? We're here, so we take it out. Lots of times with plicas, patients will complain of clicking or catching sensation in their knee along with the pain. A Baker's cyst, this is really a popliteal cyst. So this occurs when fluid gets into a normally occurring bursa behind the knee, which is the popliteal bursa. And many of these patients present with a painless lump, and all they want is some reassurance that they don't have cancer in the back of their knee. And if it's a painless lump and you know that it's a Baker's cyst, if it's not too big, they don't need any treatment, and it'll be perfectly fine. And it's a very benign feeling thing when you feel it. Malignant things tend to be hard. They tend to be non-tender. They tend to be fixed. This is very soft or relatively soft. It's freely movable. And sometimes when you push on it, it hurts, but not always. If you've seen a couple of Baker's cysts, when you start seeing them more regularly, you have the confidence to say, yep, this is another one. It's a Baker's cyst. So these patients don't need any further treatment. They just need some reassurance, and that's about all they need. Occasionally, the patients will have pain associated with it, and sometimes the pain is more coming from inside the knee than rather the back of the knee, and you can get a history maybe of an injury, and what the patient has that's causing their pain is actually a torn meniscus. So we put a scope in the knee and we deal with the torn meniscus, and 80% of patients who have a torn meniscus and a Baker's cyst will have all their symptoms resolve if we just do the scope part. So we don't do anything with the cyst. We might try putting a big needle in the cyst and trying to draw off the fluid, but usually if these cysts have been there a while, the fluid gets too gelatinous and won't come out through a needle. The last thing you want to do is just make a cut in the cyst and then start sucking out the cyst fluid. That's going to be a major failure. You have to dissect out the cyst. That's the only way you can do this successfully. And that's a bigger operation with a big incision, and we usually don't recommend it to patients. So 80% of patients will have resolution of their knee pain if they have a torn meniscus and a popliteal cyst if we just deal with the torn meniscus. 20% will continue to have knee pain, and those patients you need to go back in and do your surgery and take out the cyst, but it was worth a shot. Occasionally you'll see a cyst that's very big. Of course, whenever you see a meniscus, a Baker's cyst, you do an MRI on those patients all the time, and you see that the cyst is really big, and when you examine the patient, you palpate the cyst, just pushing on the cyst, the patient says it hurts. Those patients, it's best right from the beginning to tell them we're going to do the scope, we're going to take care of the torn meniscus, and we're going to take out the Baker's cyst, because those patients, because it's really big and it's already tender, they're going to have a problem with it post-op, so you might as well just subject them to one general anesthesia and do the whole thing. Osteochondritis dissecans, also known as OCD. See, this is where abbreviations can get you into trouble, because when an orthopedic surgeon says OCD, I can tell you he does not mean obsessive compulsive disorder. Okay. On the other hand, when a psychiatrist says OCD, I can tell you he does not mean osteochondritis dissecans. So you have to look at the abbreviation in context. So OCD in the orthopedic world is osteochondritis dissecans, and this is basically sort of an avascular necrosis problem where a patient loses circulation to some subchondral bone, and again, mostly in males rather than females. These patients will present with pain on activity. Usually there's no history of trauma. They'll have stiffness and swelling in the joint because this is the knee. If a fragment breaks off and becomes a loose body, they can have locking episodes because, again, as they bend and straighten their knee, they pinch that loose piece that's floating around, and it creates pain. Sometimes the loose piece gets stuck in some of the soft tissues around the joint and just sits there and becomes less problematic, but more often than not, it continues to be problematic. These patients on physical exam are going to have swelling and infusion. They're going to be tender over the affected area. If you do an x-ray, you'll see lucency, and it's usually over the medial femoral condyle on the femur, right? Medial femoral condyle is on the medial side of the femur, and you'll see this sort of blackened or grayish area that is darker than the surrounding bone. And that's usually the tip-off. The treatment is non-weight bearing. They need to protect this area. If they continue to bear weight on this, it's not going to get better on its own, and it's going to lead to some more significant problems, maybe collapse, maybe osteoarthritis. If there's a loose body in there, you need to put a scope in. You need to take the loose body out. And loose bodies, while we're talking about them, can occur from various things: osteoarthritis, osteochondritis dissecans, a fracture. These patients often present with locking of the knee, the sensation like I can't bend or straighten it past a certain point, the crepitus or crunching or grinding, some buckling, pain, swelling. On exam, swelling or effusion. Remember, effusion is very specific. It means fluid inside the joint. Swelling can cover outside the joint or inside the joint. So if I say a patient's knee is swollen, I'm not really defining where the problem is. If I say the patient has an effusion, I'm being very specific. I'm saying that the patient has fluid inside the joint. If I say they have extra articular swelling, now I'm being specific and I'm saying their swelling is outside of the joint. So it's the soft tissues around the knee. And these patients with loose bodies can lose their range of motion. If they're having problems, they need a scope. If they're not having problems, it's just an x-ray curiosity. Assuming that you haven't had to treat the underlying cause, you don't really have to deal with the loose body. Avascular necrosis, again, you can get it in the knee. It's the same as what we described in the hip, but it's less common in the knee. And the patients will present very much like the OCD, except this is avascular necrosis. It's the OCD involves the cartilage mostly and the subchondral bone. This is the bone. Okay, so AVN is always the bone. The x-ray will show this radiolucent defect. And again, protected activities. If the patient doesn't respond to conservative measures, at some point the bone is, or the joint is going to collapse and the patient is going to need a joint replacement. Patellofemoral disorders, these are problems with the extensor apparatus, much more common in women than men. And this can be particularly difficult to treat in young athletes. And it's not because it's necessarily because it's super difficult to treat. It's just the nature of the patient that you're dealing with. A lot of times with these young female athletes, young male athletes too, the parents are involved, and sometimes the parents are really, they know their kid is good in a certain sport, and they see the potential for a scholarship, and they're pushing their kids to participate in the sport. And the kid is sort of ambivalent. They initially loved the game, but now the more their parents push them, the less they love the game. Now their joint is hurting, so there's that aspect of it. And all of this extra medical stuff outside the realm of patient, provider, how do I treat this problem, is superimposed on everything that you're trying to do. And I know most of you don't understand extensor apparatus problems, but some of you have backgrounds as athletic trainers or physical therapists, perhaps. And, when I tell you that I would see a patient on Wednesday who had a significant patellofemoral alignment problem, and their mother would actually say to me she needs to be ready to compete in the nationals on Saturday. I just want to say, what, are you crazy? There's no way this girl is going to compete in the nationals on Saturday. Just forget about it. We shouldn't even be having this conversation. How about your daughter's knee? Isn't that, The Nationals are on Saturday. She's got a whole lifetime she has to spend with her knee. So it's just not practical. You're not going to get the patient ready that fast. And so, again, this is what superimposed. It just makes it harder to treat. The other problem is, 12, 13-year-old girls, they're starting to get their periods emotionally. They're very labile. A lot of them just look at all adults as a bunch of jerks, and it's not so easy sometimes to treat these people, and it impacts your ability to get the patient well, and it can just sort of, be that wedge between you and the patient, trying to get them better and get them back to their sport. Most of these patients are going to present with anterior knee pain. I mean, that's pretty much the way they're going to present. Chondromalacia is basically just a softening of the articular cartilage. In this case, we're talking about the patellofemoral joint. Chondromalacia is really one step on the way to osteoarthritis. The term chondromalacia has become a little bit of a catch-all for a lot of extensor apparatus dysfunction. So chondromalacia for a while there was a little bit like growing pains. When I was a kid and you went to the doctor and your knee hurt or your elbow hurt or whatever, the doctor laid his hands on you and turned to your mother and didn't even do an x-ray and said, it's growing pains, he'll get better. And we did get better. Whether there was growing pains, I don't even know what growing pains are. I never learned about growing pains in PA school, but anyway, that was it. So extensor chondromalacia has become the catch-all for knee problems. So lots of patients will come to you and say, I have chondromalacia in my knee. It's this catch-all now for patellofemoral disorders. But again, literally chondromalacia means softening of the cartilage. We used to use the phrase patellofemoral arthralgia. All that really means is a painful patellofemoral joint. That was a great way of characterizing this. I used to love this until they said we couldn't use it anymore because it wasn't really a diagnosis. It's like headache. Headache isn't really a diagnosis. It's a symptom. You have to find, is it migraines? Is it chronic daily headache? Is it an aneurysm? What's the cause of the headache? That's the diagnosis. So they took PFA away from us, and then we had to think of other things. So we said excessive lateral pressure syndrome. And it's amazing when you throw the word syndrome on there, and all of a sudden, there it was, a code. That's what we're looking for. We want a code. And we had a code for excessive lateral pressure syndrome. So when the patients came in now, instead of PFA, they had ELPS. You got ELPS. So anyway, these disorders are really just a continuum of dysfunction of varying degrees of the extensor apparatus. So some patients have a little bit of problems, some patients have a lot of problems. Most patients never came to surgery for extensor dysfunction. Occasionally we had patients who we had to do surgery on. Even the surgery was a continuum. Some of them got just what we call the lateral release. Some of them had a realignment of the tibial tubercle. A lot of it was driven by how bad the patient's problem was and how much treatment they needed to get them back. Again, a very important part of all this is the vastus medialis oblique. The strength of that is very important, and it contributes to the extensor apparatus. So when the patella gets off track, it creates this pain. It creates also an apprehension sign. Remember in lab we talked about you push the kneecap laterally, the patient gets nervous. Same thing like when you bring the patient with an unstable shoulder into external rotation and abduction, the patient gets nervous. And the reason they get nervous is because they have an unstable kneecap. Their knee has learned that this is not a good position for it to be in, and that if you pushed hard enough, you could dislocate their kneecap. So they get apprehensive. It's not really pain, it's apprehension. And again, the tendency for these things to present is just about puberty in females. Much more common in females than males. I didn't see a whole bunch of males with this problem, but I saw a boatload of females with this problem. So again, what's the typical history? It's often a young female with often vague, achy anterior knee pain and crepitus. They'll tell you that they can't, if they do activity for a long time, it hurts. They'll tell you that stairs are a problem, and usually going down the stairs is more of a problem than up. Sometimes they say both, but a lot of patients will notice that going down is more of a problem because when you go up the stairs, most of the work is being done by your flexor apparatus. You're pushing yourself up the stairs, and your hamstrings are doing the work. When you come down the stairs, your extensor apparatus acts as a brake. So you block your knee out to stop your knee and prevent your knee from buckling as you're coming down the stairs. That's the natural way to come down the stairs. So when you lock your knee, that's when the patellofemoral problems are at their worst. So these patients will give you a history often of stairs being a problem, and many of them will tell you going down the stairs is worse than going up the stairs. Sitting for long periods of time becomes a problem too, because just the nature that the knee is being bent for an extended period of time. So these people don't like to go to movies, or if they go to a movies, they want to be in the aisle seat so they can stretch their legs out. They get restless. They want to get up and move around to get some relief. They don't like to take long plane trips. And they definitely don't like to sit cross-legged, sort of Indian style, where both your legs are crossed and your feet are kind of in your lap. They definitely don't want to do that. Their pain is often relieved if they completely extend the knee or when they rest. Meniscal tears, the patients rarely have pain at night. Unlike meniscal tears, these patients with patellofemoral problems almost never have pain at night. They have no swelling or effusion of the knee. They don't like their kneecap manipulated, though. When you move their kneecap around, they usually complain that there's some soreness associated with that. Many times these patients have the same characteristics on both knees. In other words, you look at the two patellas and the alignment is the same. You look at the x-ray, the alignment is the same, but only one knee is bothering them. That's very common. Who knows what little things there are that makes one knee hurt and the other one doesn't hurt. And one knee will have an apprehension sign and the other knee won't. So again, it's kind of funny that, you look at the knees and you say, geez, these two knees look like twins. But yet the patient says, yep, this is the one that's killing me and the other one doesn't bother me, not one bit. And again, many times these patients their knee problem is triggered by an injury to another part. So again, they injure their ankle, they withdraw from their sport for a while to recover, and then their quadriceps gets weak, and their quadriceps is one of the things, because their legs were well conditioned because they're an athlete, so their quadricep was the one thing that was keeping their knee in proper alignment. Now they get deconditioned, and so their kneecap becomes symptomatic when they do high demand activities. So on exam, positive crepitus, don't worry about the Q angle. You don't have to worry about that. They'll have a positive apprehension sign. They'll have peripatellar tenderness. What I mean by that is as you palpate around their kneecap, they'll tell you that bothers them. I mean, palpate around your own kneecap. If you have a normal kneecap, that shouldn't bother you at all. And these patients will say, that bothers me. It's sore. They'll have little or no swelling. With the knee fully extended, there is often tenderness over the patella tendon. So you push on the patella tendon with their knee out straight, and the patient will say, yes, it hurts right there. So you find the point of maximal tenderness on the tendon, and then what you do is you flex the knee with your finger still on that same spot. So you haven't moved your finger. The only thing that's changed is the position of the knee has gone from extended to flexed. And you push with the same force that you were pushing before. And with the knee flexed, now the patient will say either that doesn't hurt me at all or it hurts me, but much less than it hurt me when you pushed on it with the knee extended. That to me is almost a gimme to say that this patient has extensor apparatus problems. Because what you're doing basically is with the knee in extension, the patella tendon is engaged, and therefore if there's some tenderness in it, it's going to be at its worst. With the tendon with the knee flex, the tendon actually relaxes, and so it doesn't bother the patient as much. If they had a bruise over their tendon, it wouldn't matter which position they were in, it would hurt them equally. The squeeze test, if you do it, has to be done very gently and very slowly. Basically, what you do is you hold the quad tendon just above the patella, and as you're holding it and gently squeezing it, you ask the patient to slowly contract their quadriceps muscle and tighten it. And the combination of them tightening their quadriceps muscle and you squeezing the quad tendon will give the patient a lot of pain. If the patient tightens their quad too quickly or you're squeezing their tendon too vigorously, the patient will come right off the table. It really does hurt. So that's why it's important to say to the patient, you have to slowly tighten your tendon. Okay. The x-rays would be normal except that skyline or sunrise view, as we called it before. Either one is acceptable. That view would be abnormal. So you would see some tilting of the patella. And I think I have, this is it. So again, look at this, very healthy patella. Look at the space between the patella and this area in the femur. The alignment is perfect. Everything is great. This is a very healthy looking patella. This is a not so healthy looking patella. There's already some degenerative disease. You can see that the patella isn't quite fitting in there just right. The space here is a little bigger. The space here is virtually non-existent. Here's a patella that's really out of alignment. I mean, you can imagine every time this person bends and straightens their knee, look at the joint space here. Over here, it's gone. A lot of sclerotic bone here because, again, of the pressure. This is an osteophyte. This is an osteophyte. This is an osteophyte. This is really bad. I see, again, PFA. We can't call it that anymore. But this was really bad PFA, grade 3. So these are tough to treat. Patients come to you in the middle of their season and forget about trying to get this better while the athlete is still playing. It's not going to happen. So at that point, you have to tell the athlete, you have to make a choice. Do you want to finish your season, but you're going to play with pain, or do you want to withdraw from your sport and get rid of your pain? But you can't do both. Most of the time, a lot of the kids will say, I don't want to play. This is just bothering me too much and too frequently. So a lot of times they make their own choice. It's better to give them the choice sometimes. Most of the time, their body will tell them to do the right thing, even if their heart and their brain aren't telling them to do the right thing. But a lot of times it's tough. With a kid this age, it's best for the kid to think they made the choice rather than thinking that you forced them into making a choice. The treatment would be rest, icing, anti-inflammatories. You want to avoid provocative activities. So, this is one of those, if it hurts, what do I do if it hurts? And the answer is, if it hurts, don't do it. And then a stabilizing brace or something called McConnell taping. McConnell taping is a taping that's often done by the physical therapist or an athletic trainer. It's a very specific taping, and it helps to realign the kneecap into a better alignment. If this taping is done properly, and a lot of people do McConnell taping, but it doesn't mean that they all know how to do it properly. But if this taping is done properly, it's dramatic how much relief the patients can get with it. The problem is the tape, if the patient leaves the tape on for an extended period of time, the tape starts causing its own problems. But if you have a good therapist and they know how to do the taping, you can go back and they can retape it as long as the skin doesn't start breaking down. There are braces that can be used, but frankly, the braces don't work better than the McConnell taping if it's done right. You have to rehab these patients slowly. They have to do stretching exercises, particularly the hamstrings, because when you examine them, you're going to find that most of them have very tight hamstrings. And the one thing that you want to avoid with these patients, because what you want to tell them is eventually we're going to get your quad stronger. That's going to be an important part of getting you better. The problem there is the first thing that people want to do when you tell them to strengthen their quad is they want to do leg extensions with weights down at their ankle or resistance down at their ankle. And that's the single worst thing that they can do. Because think about it, every time you straighten your knee with a weight or resistance down at your ankle, your knee is the fulcrum for that long angle, that long lever arm. And the amount of force on your knee is far greater than the amount of weight that you have down at your ankles. And I forget what the ratio is, but it could be as high as 4 or 5 to 1. So if you've got 30 pounds down at your ankle, as far as your knee is concerned, that's like 120 or 150 pounds. It goes up from there. So you're only stressing an area that is mightily inflamed and hurting by doing that. If patients want to use weights at their ankles, they can do that. But the key is to do the exercise with the weight at your ankle and keep the knee locked. So you might want to lie down and put weights down at your ankle and do straight leg raises like that. That's going to strengthen your quad too, not quite as effectively as the extensions, but it will strengthen your quad, and it will do it without beating up on your kneecap. Patellosubluxation is taking this problem to another level where patients have actually dislocated. When you have a subluxation, it means that the instability is so significant that your kneecap has on occasions actually popped out of the joint. But with a subluxation, it pops out of the joint and then spontaneously reduces. So it pops out, comes back. A dislocation just means that it popped out and stayed out. Okay? So this is the next order of magnitude from PFA. These patients often have these subluxations, and the subluxations will always be lateral. So the kneecap will slip off on the lateral side. And so if you push their kneecap towards the lateral side, which is what an apprehension sign is, these patients will really freak. These patients go, whoa, they really get nervous. So be gentle. Don't push too vigorously because, again, these patients have a track record of that kneecap going over the side. So you don't want to be the one who pushes it over the side. If you see a patient with a subluxation, in other words, they subluxed, sometimes patients dislocate. It's an extremely painful injury. If you dislocate your kneecap, it's agony, okay? And you tear the tissues on the medial side of your knee. It's really painful. And what happens with a lot of these patients is they're in pain. They're obviously on the ground. The ambulance comes, and the ambulance guys, the EMTs, pick the patient up to put him on the stretcher. And a lot of times the maneuver of picking the patient up and putting them on the stretcher will get the kneecap to pop back into alignment. The patients still have a lot of pain, but that agony pain has now been resolved. That was always the best way for me, if I was going to see the patient, was, my knee dislocated, but when they put me on the stretcher, it went back in. Okay, that's good, because now I'm not the one who has to push it back in. So, and that's what happened.